So we're going to go from interesting things like pre-excitation, prolonged QT, and ventricular extrasystoles to things that are probably not so exciting, such as isolated axis deviation, atrial enlargement, and right bundle branch block. But let's start with a question. A 22-year-old black soccer player had a 12-lead ECG as part of a pre-tournament cardiovascular assessment. He was asymptomatic and did not have any family history of note. His physical examination was normal. Which of the following anomalies requires further investigation? A, sinus bradycardia and left atrial enlargement. B, sinus bradycardia, left atrial enlargement and left axis deviation. C, sinus bradycardia and right axis deviation. D, sinus bradycardia and right atrial enlargement. And E, sinus bradycardia and left ventricular hypertrophy without lateral ST segment depression and T-wave inversion. So for the sake of time, the correct answer is B, sinus bradycardia, left atrial enlargement, and left axis deviation. And that's if we go back to this thing that we've looked at. If we look at the borderline section, you will see that our athlete has left axis deviation and left atrial enlargement. So he has two of these things in the middle, and that puts him into the abnormal category. Let's do a second question. A 22-year-old white soccer player had a 12-lead ECG as part of a pre-tournament cardiovascular assessment, asymptomatic, no family history, normal physical examination. Which of the following is considered within the normal category? A, left axis deviation, B, left atrial enlargement, C, right bundle branch block, D, left bundle branch block, and E, Sokolov-Leon voltage criterion for right ventricular hypertrophy without strain pattern. By that I mean without any ST depression or T-wave inversion in leads V1 to V3. This should be easy, and the correct answer is E, Sokolov-Leon voltage criterion for right ventricular hypertrophy. I'd like to now kick off by telling you that we thought we did great things in 2010 when we tried to differentiate between physiology and pathology by creating group 1 ECG changes, which are physiological, and differentiate them from group 2 ECG changes, which are pathological. But over the time, we realized that this was wrong with a very high false positive rate, as high as 23%. And the question is, why was that? Well, this data was derived from a very large unselected Italian population, 32,500 individuals. They were all white, and they were entering athletic activities for the first time or were amateur athletes. And the prevalence of sinus bradycardia in this group was only 1%, so they weren't really athletes. This was derived from a non-select bunch of couch potatoes, and as a result of that, there are two things that went terribly wrong. That T-wave inversion was counted as abnormal in everyone, and we got the wrong levels for QT intervals. We know that anterior T-wave inversion is present in black athletes, it's present in endurance athletes, it's present in women, and it's present in children. So if we just accounted for this, for T-wave inversion, we'd get lots and lots of false positives. And Mike Ackerman has already told you the QT story, in that we now use longer QT intervals. The Seattle criteria did some great things. They accepted the T-wave story for black athletes. They accepted T-wave inversion in V1 to V2 in all athletes, and they changed their QT cutoffs for short QT and long QT. It still wasn't satisfying enough, because there are all these non-specific changes, such as left atrial enlargement, left axis deviation, right axis deviation, and voltage criterion for right ventricular hypertrophy, which made up 50% of all positive ECGs in athletes. So when we look at this bar chart, which you've seen, black athletes versus white athletes with all the different anomalies, the question I had was, what's the significance of right ventricular hypertrophy, atrial enlargement, and axis deviation if you find it on its own? Because our experience was we didn't really find any abnormalities if these things were present on their own. But clearly we had to prove it. And this study, again, John Dresner talked about it briefly. We looked at individuals with axis deviation and atrial enlargement to see how many of those had pathology. Our definition of axis deviation, left axis deviation, was left axis was minus 30 degrees, right axis, where the QRS axis was plus 120, right atrial enlargement criteria, John's already told you, P wave more than 0.25 millivolts in the inferior leads. Left atrial enlargement, P wave more than 0.25 millivolts. Right atrial enlargement, P wave more than 0.25 millivolts in 2, 3, and AVF, and left atrial enlargement, biphasic, P wave in V1, V2, more than minus 0.1 millivolt, and certainly the terminal component more than minus 0.1 millimole in depth, and the duration of more than 40 milliseconds. We looked at nearly 2,550 elite athletes, nearly 10,000 asymptomatic non-elite athletes, and all the athletes underwent 12-lead ECG and echocardiography. Of the non-athletes, anyone with axis deviation and atrial enlargement was subject to echocardiography. We also looked at 171 individuals with hypertrophic cardiomyopathy, of which 140 were sedentary, and 31 were asymptomatic athletes with hypertrophic cardiomyopathy. And this is what we found. That of the group 2 changes, the vast majority were T-wave inversion, not surprising, but 11.2% had left axis deviation, 8.5% had right axis deviation, 16.4% had left atrial enlargement, and 6.4% had right atrial enlargement. Indeed, these 4 anomalies made up 42.6% of all group 2 changes. They made up 5.5% of all abnormal ECGs in athletes when they were found in isolation. When we actually looked at the 139 athletes with axis deviation or atrial enlargement, we found none with cardiomyopathy. We found that the prevalence of minor congenital or valvular abnormalities was no different to those who did not have these abnormalities. We found that they had normal indices of systolic and diastolic function, but they had the ones with left axis deviation and left atrial enlargement had larger LA and LV dimensions on echo. They exercised for more than 20 hours per week, suggesting that in the vast majority, axis deviation and atrial enlargement, certainly left axis deviation and left atrial enlargement, represented a physiological phenomenon. What about the controls? 7.6% of our sedentary individuals had either axis deviation or atrial enlargement. The prevalence of axis deviation and atrial enlargement in our controls was less than in our athletes. When we took these 440 individuals with axis deviation and atrial enlargement and we tested them, none had evidence of cardiomyopathy, and the prevalence of minor congenital abnormalities was no different to those who did not have these changes. If we look at the American experience, Aaron Bagish's group looked at 510 athletes where they compared ESC 2005 criteria with ESC 2010 criteria. They had 49 individuals with abnormal ECGs. Of these, 61% of all abnormalities included axis deviation or atrial enlargement, and none of these athletes were diagnosed with cardiac pathology. So our conclusion, we then looked at the hypertrophic cardiomyopathy patients. We found axis deviation or atrial enlargement in only 9 patients. 6 had mild phenotype. All were symptomatic or had a family history. Remember, the ECG means nothing if someone's asymptomatic or has a family history of cardiomyopathy. We found axis deviation and atrial enlargement in none of our athletes with hypertrophic cardiomyopathy. They had other abnormalities. And based on this, we concluded that axis deviation or atrial enlargement in isolation on its own rarely represents pathology in young athletes. It's an uncommon finding in hypertrophic cardiomyopathy patients. It's absent in athletes with hypertrophic cardiomyopathy. And when we removed these patterns, we found that the sensitivity remained 90% and the specificity increased to 94%. Right ventricular hypertrophy, just to say that we also considered right ventricular hypertrophy as a normal variant after this study, but I don't want to talk about that in any more detail. Based on this, we defined the refined criteria, which John Dresner's already talked to you about, And what we found, that sensitivity for serious conditions, it was 100%. The specificity in white individuals was 94%, but the specificity in black individuals was still only 84%. And I came to Seattle, and we all had a big meeting, and this is what I had in mind, that in group 1, we would now put in the right ventricular hypertrophy, but we had all these minor changes, axis deviation and atrial enlargement, that needed to go into the borderline category. For the first time, we were going to introduce a borderline category. And we did that, and John Dresner's already been through the international recommendations. But the one gnawing point was this right bundle branch block story. Where should it sit? Should it sit in the borderline or clearly abnormal? Well, this is the story. These are the biggest studies I could come across in athletes. And you may say, but there have been so many studies in athletes. Now, one of the problems with all the studies, including some of ours, we have not commented on the prevalence of right bundle branch block. But if you look at studies going from 32,500 athletes all the way down to 1,300 or 4,000 athletes, you find that the prevalence of right bundle branch block is not that high. The highest value I could get was between 1 and 1.2%, but no higher than that. There was one study, and this is what swayed us a little bit, 510 university athletes, mean age 19 years old, over 50% who participated in football and rowing, where the prevalence of right bundle branch block was 2.5%. This small group of athletes were all, 60% were endurance athletes. They seemed to work harder and they had slower heart rates. And in this study, these individuals with complete right bundle branch block had a bigger right ventricular end diastolic area than individuals with incomplete right bundle branch block and individuals with normal Curis complexes. And I was happy with that. But they also had a low right ventricular fractional area change. And they also had interventricular dyssynchrony. Now you could argue, is this physiology or is this pathology? The only saving grace was that none of these had cardiac disease. So, reluctantly, I would say, my perspective, we moved complete right bundle branch block from abnormal into the borderline category. But if you ask my personal perspective, I'm not 100% sure we've got that completely right so far. So in conclusion, isolated axis deviation and voltage criterion for atrial enlargement are common in athletes. The majority are found in isolation and do not represent significant cardiac pathology. The significance of complete right bundle branch block is still unclear, but this pattern has not been associated with overt pathology in asymptomatic athletes. Thank you very much.